Brian, thanks for speaking this morning. You mentioned the most common or the most problematic or largest health condition in the United States. What is our biggest health condition currently?
Well, believe it or not, it's actually chronic pain. When you think of all of the chronic conditions that are out there, cancer, diabetes, heart disease, chronic pain affects more Americans than all of those combined. And then even beyond just the prevalence, the cost, the financial burden of chronic pain is larger than cancer, diabetes, and heart disease combined. So with all of the heart surgeries and the chemotherapies that people are doing in cancer and all those very, very costly things, chronic pain with its medications and treatments and surgeries from a healthcare cost standpoint, and then all of the societal costs, because when someone has chronic pain, it affects every aspect of their life. And so it's affecting their personal life, their ability to work, etc. It's really a huge societal challenge.
What do you think that we can do to address this issue?
Well, that's a loaded question, Dr. Edwards. I think there's a lot to be done. I think for a long time, pain has been treated as a symptom. And I think, with advances in, practices like yours that are state of the art and some of the advanced science that's happening out there, we're getting a much better understanding that pain is not just a symptom, that there's a functional component to pain, where it's happening in the body. There's a sensory component in the brain, there's a behavioral component, there's a cognitive component, there's all these different components of pain that make it more sophisticated than just a 0 to 10 scale or a set of smiley faces to frowny faces. And as we understand the disease that pain is, we'll be able to diagnose it better, we'll be able to assess it better, we'll be able to monitor it better, we'll be able to treat it better, just by understanding it better.
I liked how you talked about this very complex situation, very problematic healthcare condition, and we've distilled it down to a pain score with a set of emojis to evaluate it, and how that's really not an adequate way of understanding what's really going on. It's too simplistic and almost as an insult to what a significant problem it is. I actually really liked your example about the diagnostics that have happened in cars over the last several decades. Could you tell us just a little bit about what happened there?
Sure. So I guess dating myself, like I remember when I got my first car when I was a teenager, if there was an issue with the car, of course it was nice because back then I could change my own oil and all that type of stuff because it wasn't all computerized. But if there was something wrong with the car, you would take it to an auto mechanic and they would examine it. You'd leave it with them for a period of time. And after that examination, they would come back and say, well, I think it's this, and I think we need to fix this. And then you would go to another auto mechanic and get a second opinion and say, well, here's what I think is wrong with the car. Can you figure it out? And then they would do an exam, and based upon their skill set and their understanding, they would give an opinion. And the thought process was, okay, well, if you can collect a first opinion, a second opinion, maybe a third opinion, that would hopefully validate what was wrong with the car, and you would get a sense of what was wrong. And hopefully, speaking with good auto mechanics, people that you could trust, they would be smart enough to figure out what was wrong. Well, starting in 1996, so about 20 years ago, they invented something called the universal diagnostic machine. And this
30 years ago.
Yeah, 1996. 30 years ago, that's right. That's right, almost 30 years ago. I'm really dating myself. And so about 30 years ago, they invented this universal diagnostic machine. So whether you drive a Chevy truck or you drive a Porsche or you drive a Toyota RAV4, whatever it may be, this device initially used to plug into a little outlet in the steering column, and now it's a little sensor that just goes on the dashboard that has a Bluetooth that goes back to now, which is an iPad, and it tells no matter what mechanic you go to exactly what's wrong with the car. Usually it's an alphanumeric code that tells you the location, the part that's not working, what needs to be replaced. So no matter what auto mechanic you go to, it's universally established across all the different makes and manufacturers. And I think that is analogous to what we ultimately need to get to with human diagnosis. If you're in pain and you eventually say, oh gosh, I got to go into the doctor, you start at your primary care doctor. And the primary care doctor, they have to be a mile wide and an inch deep in what they are understanding. And so they may be able to do a little, and then they're going to refer you to a specialist. And they're going to refer to a specialist that they like, that they know, that they trust. And if you're in pain, that could be an orthopedic. It could be a neurologist. It could be a neurosurgeon. It could be a rheumatologist. It could be a psychiatrist. It could be a physical medicine and rehab. It could be an anesthesiologist. It could be a host of different specialists. And each of those specialists will have a different diagnostic workup to go through to try to figure out why this person is in pain. And so there's no uniformity. There's no consistency. There's no information sharing across that. And it's my hope that in some small way, the things that we're doing with Profound Ventures and the various different companies will help contribute to ultimately getting to some point where we can have that type of universal diagnostic, so a patient doesn't have to bounce from doctor to doctor trying to figure out what's wrong.
Yeah, I like that. We think about precision medicine, and precision medicine really needs to begin with precision diagnostics. And there's a lot of advancements that have happened. Imaging is particularly a lot better. Some of the other testing that can be done is better, but a lot of it needs to be improved.
Sure.
And I think as clinicians, we need to be willing to listen and take in new data, because we may not always be right, and to be willing to and humble enough to reassess our own conclusions to make sure that we make the accurate and most precise diagnostic evaluation. Because if we miss the diagnosis, we're going to have a really hard time with precisely managing and treating a condition. But I think it's really good things to think about, and very much appreciate the time that you took this morning to spend with us.
Well, thank you. I appreciate the invitation. And I think that, the folks like yourself that are treating these patients in pain are heroes. And it's a very hard thing to do. It's a lot of information to assess. When you think of the whole body of medical literature that's published, literally doubles every 72 days worldwide. It's almost impossible to have a clinician be able to stay on top of all of the leading aspects of what's happening with that happening. And so the fact that, at Summit you have this integrated approach where you bring multiple specialists together and you have grand rounds like this that allow people to share information, I just think shows a tremendous commitment to that process of learning and trying to do better, that continuous improvement. And